Welcome to the American Shoulder and Elbow Surgeons podcast. I'm your host, Peter Chalmers, a sports and shoulder surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Rachel Frank, who's at the University of Colorado in Denver. Rachel, how are you?
I'm doing terrific, Pete. How are you tonight?
Oh, I'm doing good. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, the University of Colorado, or the institutions of any of our guests. Okay, we have a very special episode for you today for one of our most popular episodes, the Giants in the Field series. And this giant is a surgeon who needs no introduction, but I'm going to give you anyway. Today's guest is superstar orthopedic surgeon and a true giant in the field, Dr. Bob Arciero. Dr. Arciero is a professor and the chief of sports medicine division at the Department of Orthopedic Surgery at the University of Connecticut. He's also the director of the Orthopedic Sports Medicine at UConn. He's an active team physician at UConn Athletics, and he's provided sports care for men's and women's basketball, football, hockey. He's also an orthopedic team physician for USA Hockey and was the lead physician for the 2004 World Championship team. Dr. Arciero is a past president of AOSSM. He has many, many more titles and roles, and we're going to get to those as we go through the pod. Dr. Arciero, welcome to the podcast.
Thank you very much. It's like I said, it's an honor to be on your show. Really, thank you.
Well, I think everyone listening probably has read your papers or knows who you are, and I'm pretty sure everybody knows the contributions you've made over the past several decades. And I want to get to all that, but I first wanted to ask you about some things that our listeners may not know, starting with your background. So you went to Georgetown for medical school, and then you did the rest of your training in the military. Can you tell us about that?
Sure. So I was a health profession scholarship recipient, and I actually took it to pay through undergrad and Georgetown. And the stipulation when I was finished was I could apply to a civilian residency program, but in point of fact, if they had a spot in the military, that I had to take that spot. So I applied to a bunch of places, and then the Army deferred that and sent my wife and I to Germany for a couple years, where I was a general medical officer. We had our oldest child over there. And then I went and trained in the military at Madigan Army Medical Center, which is in Tacoma, Washington. It's a very large medical center. It's where the 9th Infantry Division is. So lots and lots of soldiers and their families and retirees, lots of patients there. And the wonderful thing about the training I had there is we spent over a year in the University of Washington program at Harborview Trauma Center. And it was just a phenomenal training experience to have the mixture of military and civilian training. So it was a great training. I wouldn't trade my residency for anything. It was really groomed me to be who I am.
So when did you know that it was orthopedics and specifically sports medicine? Because I think with a career like you've had so far and all the things that you're continuing to do, clearly sports medicine is in your blood. When did you know and how did you know?
Well, I don't think my story is very unique. I wanted to be a professional baseball player, and I ended up tearing my ulnar collateral ligament. I'm a left-hander, but we didn't know what it was. It was the year before Tommy John had his surgery, and I was brought up to Buffalo, and Joe Godfrey of the Godfrey sign for PCLs. His room was filled with athletes, and I thought to myself, this might not be a bad way to do things. If I can't play, maybe I can do what this guy's doing. So I actually, thought about medicine my senior year in high school. And then, I'm a sports junkie. And, I sort of had zeroed in on doing something with athletes very, very early. And I think in medical school, whenever we did the extremities in anatomy, in those days, we took a whole year of anatomy. So upper and lower extremity, I was just, I said, this is what I want to do. So it was pretty early on that I knew that I wanted to do orthopedics.
Okay, so you've decided to do orthopedics, you've done your training. Tell us where you went from there.
So I think it's an interesting story. I mean, if you're in the military, you might think this is interesting. So probably my biggest influence, my mentor role model was actually a trauma surgeon, Bob Winquist. And I spent 6 months on his service. And I thought, this is the kind of doctor I want to be. He was not only competent and well read, but he was fabulous with patients. He was fabulous with people. He was just, he was just a tremendous role model for me. And I wanted to do trauma. So when I was a chief resident in the military, you have to talk to the orthopedic consultant because they're in charge of your life. And I wanted to go to Fort Bragg and or Fort Benning and do trauma. That's really what my interest was at that point. But an unexpected opening became available at the United States Military Academy, but I knew it was going to take me away from trauma and put me into sports medicine, which was okay too, obviously. But that assignment was really off guard for any resident graduating. And I remember going to Dr. Winquist and I said, I think I want to do trauma, but the Army has put this in front of me. And I'll never forget it. He said to me, sometimes you have to take what life gives you. And this is 1987. And he said, I think there's really going to be something to this sports medicine thing. That's what he said. And so I ended up going to West Point, and that's how that all started. But I really originally wanted to be a traumatologist.
So in line with that, at West Point, you obviously took care of a lot of active athletes. You've published in this area, a million papers in particular on shoulder instability. Is shoulder instability surgery your favorite surgery now, or do you have another preferred surgery, anywhere throughout the body?
That's a great question. I do shoulder and knee instability surgery, and I think some days I like shoulder instability surgery better, and then other days I like a revision ACL with a posterolateral corner. I mean, I really enjoy the two joints and the instability component of it. I love doing open shoulder surgery as well as arthroscopic. So I guess if I had to pick one over the other, I'd pick shoulder over knee. But like you spoke about Gus Mazzocca, who was my partner for 22 years. He goes, nobody knows how much you love the knee, and that is sort of true. I certainly haven't published as much in the knee, although I have done some publishing there. But I would say shoulder is probably number one, but not by much.
I'm so glad that you're on this podcast because when I team up with Pete, every time I mention the word knee scope or ACL, I feel like through the computer, his eyes are staring down at me saying, you can't say those words on this, on this episode. So thank you for being here just for that alone. Let me ask you.
I think I'm just gonna edit all this out.
You better
we're just gonna
not,
take
Pete.
all of this bulk out. We're just gonna, maybe you could just go back and re-answer the question.
Pete, the listeners want to know. They want to know about the knee too. So, Dr. Arciero, let me ask you, with respect to shoulder instability, I think, and this, we all know this, the open primary soft tissue repair, we're not talking ladder J or bone block. It's just gone out of favor in so many residency programs where when you ask, residents if you're going to do grand rounds or you ask your incoming fellowship class, have you ever even seen an open soft tissue repair? So many have said no. I was very fortunate to train at Rush with Dr. Romeo, and we saw a few, but it was few and far between. We were either doing an arthroscopic Bankart repair or a ladder J. What is the future of shoulder instability surgery? With the shift in instrumentation and implants toward arthroscopic bone blocks, be it ladder J or a free bone block, we're seeing a big shift now in 2023. You've been doing this for a couple decades, if not more. What is the future of shoulder instability surgery?
So I do think, honestly, the future is to address all components of instability with the scope in the shoulder. So we've skirted around it. You know, we learned how to do arthroscopic stabilization surgery, and then that was our big hammer for every instability case that walked in the door. And we found after some long-term follow-up that it was not a perfect operation, and the issue was the bone. But like you just mentioned, we're getting very clever at shuttling in bone into the glenoid, doing things to the Hill-Sachs lesion, which I think is still controversial to some extent. But I think the future is arthroscopic stabilization. The problem is, just like it was 30 years ago with arthroscopic Bankart, shuttling in a piece of iliac crest or distal tibia or distal clavicle is not easy. It's not a transportable technique yet. It's not for the casual surgeon. It's not even for the casual sports surgeon or the casual shoulder surgeon. You have to have a tremendous interest in it, and you have to spend a lot of time in the lab, and you have to learn from somebody because the technique is not easy. But I do think that's the future. I do think open Bankart eventually probably will go away. And I do think Latarjet will be replaced for more anatomic methods at some point, but we're certainly not there yet.
No, I think that's just an incredible insight from, again, someone who's seen things come and go in the field. And one of the things I have a lot of respect for what you just said is that I think it's a real clear-eyed view in the way things are changing and the way things probably need to continue to change. How Tell us a little bit about how you as a surgeon have adapted to change over your career. Like, as you go to meetings, as you see new things, how do you incorporate them into your practice? Like, do you have a methodology? Do you go to the lab? Do you visit people? Do you watch videos? Like, what is your method there for trying to improve your practice?
That's a fabulous question. I've been asked that before. My fellows ask me that all the time. How did you go from pure open and then go into arthroscopic, and when do you pick and choose? And so I think honestly, I do think lab experience is really important. Video's important, but the one does not replace the other. You have to do both. And if you're really sincere about learning a technique, I think you need to go visit somebody you respect and who does a lot of that particular technique. I think you have to do three of those three things. And then what I did was, and I can really actually talk about this more with arthroscopic cuff and arthroscopic ACL. I know you don't want to talk about the knee, but so I would do early in my practice, I would do the acromioplasty, and I would look at the cuff, and I would prepare the footprint, and I place the anchors, and then I open, and then I would pass the sutures and tie. And then I would do the acromioplasty, put the anchors in, pass the sutures, but still open and tie. And I bet I did that on 50 cases before I went. I said, okay, time to be a big boy. I'm going to do the whole thing with the scope. And I did that a lot with the ACL in a stepwise fashion. Now, Bankart, the arthroscopic Bankart, I pretty much had the technique down because I had done some other stabilization procedures, such as SureTac and transglenoid and some of these other procedures that are really historical in nature. So it was all about learning how to put anchors in and tying knots, but definitely stepwise, learning from people and getting reps in the lab.
So one of the things I wanted to ask you about is and this is really a great segue from what you just brought up. You're such an incredible innovator, and dare I say it, when we do multi-leg reconstructions and I'm doing a corner, the technique I do, I call it the Arciero technique or the modified Arciero technique, and that's my preferred approach. And I only know about that because of you and having, relying on you to kind of invent that technique, and then I get to go and practice it in the lab and then do it on patients, and I'm so satisfied each time. What are your sources of inspiration? How do you come up with these types of techniques? And tell us, especially for our younger listeners, because so many of our podcast listeners are younger in their careers where they might be thinking of a new technique. Are there times when you've tried to do something and maybe it didn't go so well, or that didn't have the outcome wasn't what you were expecting? So tell us a little bit about that.
So, again, a great question. I've definitely gone down the road of doing some procedures that did not work. And I think first things first is you need to follow your patients. You need to examine them. I try to follow my patients at least 2 years. I make them come to the clinic at least for 2 years after any major joint stabilization procedure. And I'll tell you, you learn a lot from patients and you examine, and it's sort of a gut check. You have to be honest with yourself. Is that knee stable or is that shoulder stable? Or, I did this cuff repair, and do they really have their strength back? I mean, what did I do or did not do? And so I think it's a lot of self-criticism first. And then the second thing is that I've learned over the years, and the only exception to this is the latter J. Every time we do something that doesn't obey anatomy, we get sniped for it. We pay for it. So, and Peter, please don't be upset about this, but I'm going to go to this posterior lateral corner, and I was doing, a Larson or Mueller technique, and my knees were not perfect. And I said, and then I kept thinking about it, and I said, well, we're not reproducing the anatomy. We're kind of bypassing it. And I would say the open Bankart, the reason I was asked this at Issachas actually last week, why do you think an open Bankart is different than an arthroscopic Bankart? And I said, well, it's how you do it. And, an open Bankart, we not only place anchors in, but we pass sutures through the labrum capsule and tie knots on the outside and absolutely obliterate the false pouch. Is totally, and we've published this, the footprint restoration when you do that versus your little, our little spot welds with an arthroscopic is totally different. And then you shift the capsule in double breasted. So you tighten up the stretch injury and you double the thickness of the capsule. And we don't do that with a scope. And, so I think that long-winded answer, but obeying anatomy and being very critical of your own results. Calling a failure or calling a procedure not as good as you thought it was, and is really the key thing for any steps I've made or progress I've made in anything I've done.
Well, such an incredible set of insights there. I mean, I think that's the thing about the anatomy that's so interesting to me is that I think you're generally right, but there are such strong examples in shoulder with the reverse and the latter J that are counterexamples, I guess I should say, that were, I think, often poo-pooed for that reason. So maybe one of the key things here, and it sounds like you've done this, is to keep an open mind as well.
Yeah. Well, I would say, and I don't do arthroplasty, but latter J is definitely not anatomic. And I would say this about reverse. Reverse is anatomic. You're just saying we're going to bypass the cuff altogether, but we're going to rely on the deltoid, and this is how we have to engineer it to do it. So I don't necessarily say the reverse is not anatomic. It's dealing with the anatomy that works in that particular patient.
Yeah, that's fascinating. So that's a whole fascinating discussion we will have to get into another time. You mentioned you were recently at Issachos talking about the open bank art and the arthroscopic bank art, maybe unfortunately named because, as you mentioned, they're very different operations. They're not just two different approaches to the same operation. Tell us, you've worked with a lot of different societies here. You've certainly contributed to ASES. You've been president of AOSSM. You mentioned recently contribution to ISACOS. We know you've been involved with ANA. How have you managed working with all the different societies? What has been your plan of attack there?
Wow, that's a tough one, Peter. I'll tell you, I think what's happened um, is I have a lot of friends that are in each of those groups, and that's how it's worked. Honestly, I'm obviously interested in the topics that this each of the societies that you mentioned, um, will be, investing in that particular meeting or that particular year. And, I think it's also because I do knee and shoulder. And my role model for that was, Russ Warren. Russ Warren, and maybe and my predecessors and my partners at West Point. Whereas, at West Point, I did elbows, I did ankles, I did anything sports related because I was quote unquote a team physician. So we did everything. And then, I came into what I call civilian practice, and I have partners who do certain things. And after a few years, for sure, they're doing them better than I do. So I think it's the fact that I'm a team doctor that leads me to be able to interface with all of these societies, and plus the fact that I have such a strong interest in the knee and the shoulder, and my friends are running the meetings. So when they ask me to do something, most of the time I'm going to say yes.
Well, that brings us to a topic that I was really looking forward to discussing with you. And that really stems on your role as a team doc and the environment of being a team doc in 2023. A lot of our podcast listeners are shoulder and elbow only, but they take care of teams as the shoulder and elbow consultant or as the head team doc in some cases. And a lot of our other listeners are generalists or sports med docs who like you and me, do a bit of knee and a bit of shoulder. I think everyone's aware of the recent challenges that team docs have experienced with litigation, lawsuits, and even things that go a little bit unspoken or not in the public eye, but with how orthopedic surgeons testify and talk about cases, et cetera. Can you tell us a little bit about what it's like to be a team doc in 2023, and if the recent active legal concerns with some of our colleagues and friends have changed how you approach being a team physician, have changed how you interact with parents because you take care of a lot of collegiate athletes, with the coaches, or with agents when it comes to professional athletes? Tell us a little bit about that, because it's weighing certainly on my mind and likely a lot of our listeners' minds as well.
Yeah, I do think we're in a total crisis mode right now, because of the litigation issues are really they're they're not only bad for everyone, but they are really destroying the fundamental trust that you build with the team, with the athletes, the trainers, the parents. And I haven't had to worry about agents until the last 3 or 4 years, but at the University of Connecticut we have name, image, likeness athletes who are making several $1 million a year. So what's happened recently has made me pause, but it's also, I don't know, maybe I'm being extremely naive, but I really enjoy the relationship I develop with these kids. And I think one thing they know for a fact is that I'm really there for them. I'm not going to force them to do something they don't want to do, and I'm definitely not going to force them to do something a coach wants them to do when I don't think they're ready. I think they really understand that I'm their advocate, and I think that's one way that we have to challenge this is that we can't be team surgeons. We have to be team doctors. So we have to be there for all of it. And I think, we're all enamored with fixing people, but being a team physician is so much more than that. It's way, way more than that. And I think that what's going to have to happen is either schools and or professional organizations are going to have to sort of pony up and protect their doctors so that they can still manage to attract the best talent to take care of their best talent, or it's all going to go away and these kids, these athletes don't realize it, but they're not going to get the care they used to get. But it's definitely worrisome. We've had a meeting, our team docs, our team orthopedists, we've had a meeting about all this, about operative consents and going back to the university, like what is our coverage and can we handle these catastrophic claims? And I've been very, very fortunate in my whole career. I've not had one of these issues, but the people that you're talking about, they haven't had issues either for 35 years, and then bam. So I think it's going, if you're going to be a team doctor, you got to be a team doctor and really invest in the team. It means more time, more face time, more talking time. And it's not things that we want to hear because we all have families and we got to do other things and we got our practices. But I think it's going to mean more demand on us, in a relationship sense. And then, frankly, the institutions are going to have to protect their doctors.
Do you think that you can foresee a time in the future where, in particular with the pro athletes, but also with the collegiate athletes, especially with the NIL and all that, that physicians won't want to take care of these athletes, or they will want to, but they will refuse to, because we're all good, good-natured, good-hearted people. We want to take care of these athletes. That's why so many of us go into sports medicine. But do you foresee a time, I guess in particular at the pro level, where high-profile docs who typically take care of high-profile athletes might say, I'm not going to do this. It's not worth the liability. It's not worth the potential problems. Or do you
I
think
think it's already happening. I think there's no question. I mean, I think when you have a malpractice that has a cap, and then the lawyers go after your practice or your, everything you own, to get out, get way more than the cap. I do think people are going to say, you know what, it's just not worth it anymore, especially if this keeps going, if the numbers keep going up and more, legit great people, great surgeons are sued. It is, it's going to be, a hot potato. And I don't care how much you love it and how much you think that it's good for you. It's going to come to a practical sense that you can't do it. And importantly, if you're not protected, I doubt insurance companies are going to back a team doctor for $50 million. It's just not going to happen.
Well, certainly a difficult time and one where the future is somewhat uncertain. So let's move on here. I wanted to ask, you mentioned already some real heavy hitters in the history of orthopedic surgery that were your mentors. You mentioned Winquist, you mentioned Russ Warren. Who have been some of your biggest mentors, the people that have taught you the most, and tell us some stories about them.
Okay. So, the so can I go back to one that I've already talked about? Is that all right? Can I?
Of course, that sounds great.
So I have a very special story about Russ Warren. So when I came back from the Persian Gulf in 1991, my boss, Jack Ryan, who's still a very close friend of mine, orthopedic surgeon in Detroit area, he was running West Point, but he came back and like we're there a month, and he says, I'm leaving. And I'm going to San Francisco. My wife wants out of West Point. And like literally in 2 weeks, I'm about 36 years old, and the Army says you're going to run West Point, you're going to be their head person, you're going to run the fellowship, you're going to do all this stuff. So I felt obviously pretty uneasy. I was honored. I wanted to do it, but I felt like, I have gaps, I have holes, I got to, to cover. So there's always been a strong relationship between West Point and special surgery. We're like 50 miles from them. And starting with John Fagan, he had relationships with John Marshall. And, that's kind of been cultivated over the years. But I picked up the phone, I called Dr. Warren, who, you know, um, would see a cadet at the drop of a hat. And I said, I'm in charge, I'm in the fellowship now. My hospital commander says I can come down and visit you guys and just look over your shoulders. Is that okay? And he goes, absolutely. Come down every Wednesday. 3 of us are operating, and we'll give you a pass. So literally for a year, I went down there almost every Wednesday as a quote unquote fellow, and would be in Russ Warren's room, Tom Wickowitz's room, Dave Alchek's room, and I just was a sponge. And he was incredibly generous, Dr. Warren, with his knowledge and sharing what he knew and what he didn't know. I can even remember having a cadet who had bidirectional traumatic instability. I didn't know what to do. Should we go from the front, the back, both? He said, he goes, why don't you bring him down here? So I put him in my car, this cadet, and we went down on a Wednesday. And in between cases, in the HSS locker room, he's examining this kid on the floor. And, like those kinds of things. Like, so what I learned from him is share everything, good, the bad, the ugly. That's another thing I would learn from Bob Winquist. He goes, we don't have all the answers, but there's people out there who have less answers than we do. And we have an obligation to help our colleagues. He used to always say that. So those are two great examples. I learned from Freddie Fu. I got time for one more. I had just come on the AOSSM board as a treasurer, and if you're on the board, you're expected to be there. Every board meeting, everything, you can't. So here's my first board meeting, and my son is a senior playing hockey at Clarkson, and it was his senior night. And I was either going to go to this meeting and miss his senior night, or I was going to forego the. So I wrote a email to everybody on the board. I go, look, I know this is highly irregular, but I really can't go. I can't come. My son's senior night. I really need to go to his senior night. And I actually got a little flack, and I'm not going to name names, but several people said, Bob, this is you were elected to this, and blah blah blah. You signed on for this, and Freddie Fu was president that year, and he saw my email, and he wrote, "Family first, period." That's all he put, "Family first, period," and that was the end of it. And I went to my son's senior night. He actually scored a goal that night, so. So Freddie put things, life into perspective, as well as so many other things he taught me. He didn't teach me how to get by on 3 hours of sleep, though. But I think, I could go on and on about some of these people, but those are just a few of the stories.
Well, you've had some incredible mentors, and you've been a mentor to so many. And in your position and in your career, you're often the guy in charge, whether it be of AOSSM or of, within your department, within sports medicine, et cetera. Tell us, when you're looking to bring someone on, say a new hire for your division at UConn, or if you're, leading AOSSM and you're looking to add someone to the board, or at least have a say in that, because obviously there's elections and voting and all that. What are the qualities you look for when bringing on a new hire? And what are some of the potential red flags? Because again, I think a lot of our listeners are young. They may be looking at jobs, and they might not, they might have some of these qualities, but they might not realize maybe they have some of the red flags. Hopefully not. But what are the things that you look for, both positively and negatively, in young surgeons to join your group, your team, your society, etc.?
Well, I mean, probably first and foremost, and hopefully you can, gather this information. First, they got to be incredibly competent people. They're, really good in the operating room, really good with staff, really good with their partners. Hopefully, you can get some idea that team first, not me first, but team first. That to me is most critical thing uh, in anybody that would like to be in my department. Um, you know, Endless energy, no job too small, no job too big. All the cliches. That's what I want to see in a young partner. And my whole department, I have tons of young people, hand surgeons, foot and ankle surgeons, spine people. I have phenomenal young partners. I mean, they're really tremendous people, and I love being in the department with them. So those are the qualities I want to see. So how do you get that info? Well, maybe you know them. Maybe they were a resident. Maybe they were a fellow. It's a little dicier with people you don't know, and that's why you look to letters and talking to people who do know these folks. And so that those qualities, again, cliche, team first, but they got to be competent. They got to be, great surgeons, great doctors, willing to see patients at any time, and not this, I got to be out of here by 2 because whatever, unless it's some kind of major family thing. But they've got to be willing to, like the partners I have. If I was to say, um, hey, I need game coverage. All of a sudden we need somebody to cover Saturday's game and it's Thursday. Boom, they just say, I'll be there. That kind of thing. Um, and then red flags to me are, in an interview, I guess if it's somebody I know and have trained, we're not gonna hire that person because we knew that they did the bare minimum. They didn't go above and beyond when they were a resident or a fellow. And again, it's much harder when you're advertising and bringing someone in, but you can get a sense of what they've done. That's why I've always looked at not only letters, but I look at the research they've done. I look at the volunteer work they've done. Like if they've done things other than just try to get ready and pass your boards, and to me that tells me a fair amount about that person. And a red flag would be somebody who's done none of those things, and can't express to you what makes them tick. Like why are you interested in this job? Because I need a job. Okay, but what is it about this job that piques your interest? Well, I want to educate. I know that team physician responsibility is important to me. They can articulate to you, a vision, their own vision, and hopefully it's in step with yours.
Okay, so you found this person who's going to volunteer for everything. They're hardworking. They've shared your vision. You hire them on to join you, and they say, "Okay, what is your advice next? Like, what is once you have that person, how do you advise them as to how best to succeed, assuming they've got all of those great qualities you look for?"
So I really I think I'm very, very firm on this, specific on this. What makes us, I don't want to say powerful is probably a bad word, but what what makes us unique and important is our ability to be orthopedic surgeons. That's not a business person, not a lawyer, but our ability to see a patient, evaluate them, make the right, decisions, do good surgery, follow them up, and get good outcomes. So the first thing that I always is recommend to a young person is there are going to be a lot of things flying at you. The first thing is to be good at your craft. That is number one. Okay, be the best doctor you can be, and that's always my advice, because that's always held up for me. Be as good as you can to your patients. Secondly, be good to the people who help you do your job. And, it's okay to smile, maybe buy them lunch, maybe get pizza, maybe do something to make them feel like you value what they do. But as far as a young person, they got to get good at what they do first. And then the other things can happen. The research can happen. Hopefully, maybe your institution has an infrastructure for collecting data. But the first thing is be really good at what you do. And I'll tell you, it takes a long time, I think, to get comfortable at decision making, doing good surgery, and avoiding complications. That's a lot on your plate. And then, all of these other things that I mentioned, that all is within the realm of taking care of patients, whether it's athletes or just regular people. But I think that's the most critical thing. It was a very substantial part of my presidential address, believe it or not, at AOSSM is be good at, we need to embrace our craft first. Don't get sidetracked. Take care of patients first, get really good at it. Then you can morph into some other things.
I love it. I mean, that's why we do what we do. That's why we got into it first and foremost. So incredible advice. We're getting toward the end of this podcast, and I know both Pete and I could sit and pick your brain for hours, but we want to be respectful of your time. One thing we always ask when we have our giants of the field on, and so we're going to ask you as well, is if you could pick anyone, dead or alive, and go anywhere for dinner, who would it be and where would you go?
Wow. Well, this is I'd like to have dinner with my dad. He's no longer with us. So if I had the opportunity, I'd like to pull him back from the grave for an hour and a half, and take him to a really good Italian place that has fabulous Cabernets, because he's an old army guy. He was a soldier, and he bought the cheapest wine on the planet. He'd go buy these Cribari bottles of wine. They're like, 3 gallons, and pay $5 for it. Awful stuff. And when he was dying of cancer, I brought like a $300 bottle of red wine to the house. And I said, Dad, I know you'd never buy a bottle, but he goes, there's no difference. And I again had him do the old taste test. It was a Silver Oak cab. And he took a taste of that thing, and I thought his eyes were going to pop out of his head. And it was such a great feeling for him to have sort of that satisfaction right before he passed away. But if I had a choice, it'd be to have him come back and take him to dinner, as I described. He was a huge role model for me.
Well, that's definitely one of the best answers we've ever had. I want to thank you for coming on. I mean, this has been awesome. Such a wealth of good advice and great stories. And we've been really fortunate to have you on as a guest. So thanks for taking some time with us.
No, I thank Peter, you and Rachel. This has been a lot of fun. I knew it would be. when you guys invited, and I saw these the young gunslingers running the podcast. I said, "Oh yeah, I got to do this. This will be fun." Thank you.
Well, Pete's the man. I'm just the good looking one, which is why we have a podcast. So no one can prove that one way or another. Again, thank you for coming on. This was amazing. I think our listeners are really going to enjoy it. For all of our shoulder and elbow listeners out there, please don't forget to subscribe. And for Pete Chalmers, I'm Rachel Frank, and we'll see you next time.